Hello and welcome to the eCancer Roundup for ESMO 2018. I'm Will Davis, the eCancer reporter, and joining me for your 47th ESMO, I believe it is, Professor Gordon McVie.
Thanks very much. Every year gets a little bit better. Small steps forward, no breakthroughs, no massive headlines again this year, but some nice little increments, so that's good.
Okay, well, let's start with some of the news from today in head and neck cancers. The Keynote 48 trial for first-line pembrolizumab for relapsed squamous cell carcinoma. Pembrolizumab in head and neck cancer, it works in this population.
I think that's the good news. Head and neck squamous cell particularly is real tough cancer, very resistant to anything you throw at it, especially after the patients had radiation therapy plus or minus a platinum or something like that. So this is good. This is one of your nice steps forward.
And by way of comparison to the adverse events seen in the extreme, the aptly named extreme chemo arm.
Yeah, cetuximab in patients with HPV positive head and neck cancers did not do well. I think that's probably the best thing said about it. A bit too much toxicity to be taken on to the next round.
Yeah, so we've got the good news and the bad news out of head and neck there, but on to more good news again from the breast cancer sessions. We've heard fantastic stuff coming from all kinds of corners, starting with the first immune success in the Impassion 130 trial presented by Professor Schmidt.
Yes, this is a huge trial, about 900 patients or something. Paclitaxel with a nab on the end of it, all right, together with atezo, and they're looking at breast cancer failed, several lines down the way. The criteria for the PD-L1 targeted drug was having the PD-L1 staining. I have to say, and I'll say this later on, there's still quite a bit of doubt about whether this is a good biomarker or not. But there is a survival difference in these two arms. It looks like 7.2 months for the combination versus 5.5 months for the chemotherapy. So, as you say, first little step forward in a randomized trial for immunotherapy.
And once you've got the first success in PD-1 therapy, it seems like there's a lot of attention, a lot of interest in trying to get everyone else's PD-1 drugs into the space and see what can be done, and hopefully that translates into benefit for the patients at the end of the day as well.
It's not for the want of trying, because every pharma company is trying to get an immuno-oncology drug, and I've told the last count, about 400 trials going on globally on the immuno-oncology approach, right across the disease spectrum, because that's one of the exciting things. This isn't just a disease-specific approach. This is global, and that's good news.
Congratulations again to Professor Schmidt and to all of the patients being treated for the gains that they are making. And then another headline from the breast cancer news coming out of this year's ESMO, the success with the Paloma 3 trial of a CDK in HER2 negative HR positive disease.
Yes, this has been signaled last year and also a little bit ASCO, but basically palbociclib is growing roots. And the database is growing, and it's challenging now to be looked at in first line or close to first line treatment. The target's interesting, and there's no competition for that target at the moment, but there will be other CD46K inhibitors coming along. At the moment, palbociclib is out in front and good data.
It seems like they're whittling down the ways in which CDKs might not be suitable for someone to a very small degree. It seems like that anyone with a breast cancer and many ovarian cancers should be considering CDK treatment at some point in their progression through disease.
Yeah, I think we should be saying that is the optimal approach now for all cancers. If there's a biomarker which has got a link to a target-oriented drug, then that's the way you should be going, and this is a good example of it.
One last breast story coming from the second-line therapy for relapsed patients using a HDAC inhibitor called kedamide.
Yes, HDACs have had a rough time, frankly, mostly due to excess toxicity and not a lot of response. In this occasion, kedamide has actually produced a response, 20% response, which is quite a tough call in heavily pre-treated patients with breast cancer. But again, it's dogged by side effects, and about 20% of the side effects were seriously adverse. But it's a blink of hope for HDAC as another target. not on the genome, but next to it on the epigenome.
I think maybe, I guess, the summary for breast cancer news then is that watch this space. We've got the success with immunotherapy, CDKs gaining more and more of a foothold, like you say, the HDAC news, and these small steps I think are going to culminate in some very large leaps, hopefully for patient survival and the way that they can tolerate the treatment, with reference to the HDAC inhibitors.
Sure.
And see that coming. This might just be the first part of that story.
Yeah, I think the next 2-3 years and that'll be sorted and we'll be on to the next set of questions.
On to the next set of questions then. Some news from the lung cancer space. Alotinib surpassing gemcitabine in a phase 2 trial. It improved overall response and progression-free survival. Data out of a Chinese trial.
This is a neoadjuvant trial, which I think is quite exciting because if I just go back to where the next steps might be in breast cancer, I would think that's seriously into the neoadjuvant space. There's a lot of people doing it in small numbers at the moment, but I think neoadjuvant chemotherapy, immunotherapy, immunotherapy for breast, for lung, for colon, for ovary, I think that's going to be an interesting way to really make an impact on complete remission and longer term survival. So this is a nice study showing that alotinib is better than gemcitabine as far as I can see in terms of overall response rate and progression-free survival in non-small cell lung.
Yes, the neoadjuvant space seems to be taken over by quite a lot of research going on in melanoma as well. We heard some of that. But let's move on to the urothelial space. Got news out of the Javelin trial. This has been something of a headline from this year's conference. The improvements seen using avelumab, a PD-1 antibody again, with axitinib, improving PFS, response rate, but no overall survival data as of yet.
And this is in kidney cancer.
Yes.
This is the example I was referring to earlier, where there is an improvement in progression-free survival for the combination of the PD-1 target combo, but it doesn't seem to tie up with the PD-L1 staining. So the biomarkers let us down. So the great idea is biomarker. We're going to get a massive response rate from those who've got the biomarker. Not yet, I think, is my view.
And with all of the other developments that have gone into cabozantinib, we are speaking with Tony Schwery about that. It seems like there's a lot of work happening in the kidney cancer space. This is an improvement in terms of sheer response rate, but for figuring out who gets what when, there's still a lot of discussion happening there.
There's certainly no shortage of choice of new agents and new approaches in kidney cancer, which is really extremely encouraging.
Then on to some news from Gustave Roussy in Paris, from Professor Prezazi working in prostate cancer. Docetaxel and endamustine on top of goserelin, reducing relapse rate among adult patients.
Yes, these are prostate cancer patients. There's always a dilemma about how much to do up front in the new idea that up front is a good idea. In the old days, prostate cancer was treated solely by radiation or surgery, plus or minus hormone suppression, and now it doesn't look as if there is serious data that docetaxel for kickoff in high-risk patients upfront is a good idea. And here's some more data that's taking us in the same trend.
And of course, prostate cancer has been one of the main headline topics coming out of the last couple of ASCOs as well. Yeah. Huge gains seen across the board in this space. And your thoughts on where this research in terms of new combinations is taking research for prostate as a whole? In thinking again about neoadjuvant therapy, it's all to go on about it, but there's some good candidates. There's enzalutamide and abiraterone, which have been terribly good in patients with later disease, and they're working their way up front. And I think neoadjuvant approaches, I think probably in this instance with chemotherapy, because of the data on docetaxel and the data with some endamustine docetaxel presented by Fezazi here, I think that's going to show some good effects in the next couple of years. I would think so. And then also good news in the ovarian cancer trials for SOLO-1 using olaparib as a maintenance therapy, 2 years of treatment, and then survival at 3 years is one of the big successes from the conference, as I can tell.
Well, I think it's the best data, frankly. and it certainly will have the most impact on a really rotten disease, which is ovarian cancer. We rarely ever cure patients with ovarian cancer if it's stage 2 or bigger. We get nice responses and they last for some years, but then this disease comes back, and it's a real problem. And I think that this is a courageous study based on good science with the PARP inhibitor, etc. But to do a placebo trial of maintenance for 2 years against a drug like olaparib, I think that took a fair bit of risk. And it has paid off. I mean, this is a terrific result. I mean, the progression-free survival for patients who got the placebo was 13.8 months. That hasn't been reached yet in the olaparib group, and they're out 3 years on. So I think this is terrific, and this is going to generate a lot more interest in ovarian cancer, which frankly has been a little bit overlooked over the last wee while.
I think PARP inhibitors alongside CDKs is one of the treatment modalities which more data comes out year by year that, like you said, with CDK gaining a foothold, gaining roots, it's just proving to be a great treatment option for many, many patients.
Yes, I think it's much bigger than we originally thought, which was going to be useful in BRCA1, BRCA2 mutated patients with breast cancer, or then it was BRC less, and then it was ovarian cancer, then triple negative. But actually, it's probably going to be wider than that, and I think it's a good drug, and there are a lot of other PARP inhibitors coming along, and this is good science translated into good clinical practice, good for patients.
What we like to hear. And then also in colon cancer, we've got the combination of checkpoint therapies in Checkmate 142, using both ipilimumab and nivolumab together in this trial.
Yeah, I think this is great, actually. The theory was going to be one works and not cross-resistant with the other, therefore put them together. That was not a massive success in lung cancer, which was announced about a few months back. But here it seems to be paying off with big response rates up about the 70-80% mark, really quite impressive, and good overall time to regression and time to relapse. So I think this is one up for the immuno-oncology boys who've again had the courage to take a bit of risk. We could have had maximal toxicity, they could have additive toxicity. Toxicity doesn't seem to be massive, 16% serious toxicity. This risk paid off too. So that's good for immuno-oncology.
And to clarify, that's in a somewhat smaller subset of patients with DNA mismatch repair deficiencies or microinstability high tumours.
Yes, this is a small subsection of colorectal cancer, but it's 5% maybe with mismatch repair issues. But 5% of a common cancer is good news for those patients, and the whole notion of finding your mutations or your epigenetics or your proteomic errors in tumors, and then going into more educated, intelligent treatment. I think that's paid off. I mean, when ALK was uncovered in lung cancer, non-small cell lung cancer, we thought, well, that's not very interesting. But now, after crizotinib, we've now got 2 more candidates which are doing even better than crizotinib. And lung cancer is a very common cancer, and this is a big step forward in non-small cell lung cancer, as it now is in colorectal cancer. It's really good. It's a way forward. Small steps, small increments. We have to be patient.
All these small steps in personalised medicine, I think if there is a way to summarize the conference overall, it's that the personalized and precision techniques are being employed widely by many people across the world in many different trials, and success is happening.
Yes, it's obvious from here at the exhibition stand. There's still precociously expensive stands around the place from the pharma companies, which I'd rather see going into patient care, and lower costs of medicines, but they're all looking at immuno-oncology. There are 4 or 5 companies here who've got genetic testing on tap, with recommendations on the matching to drugs and so on. And I think that's showing the way that it's going to go. And I'm very pleased with it. It's only my 47th ESMO, but it's certainly the brightest in terms of patient care overall, taking the last few years into account. Yeah, very positive.
Speaking of better ways to spend one's money, the Biosimilar Symposium from this year's ESMO leads into a lot of stuff that, eCancer has the educational module out about what biosimilars are and how they can be used, and based on survey data that has been discussed by Professor Volto and Professor Lufner, there is a need for education and understanding about what biosimilars are.
Yeah, they're identical drugs, or they're near identical drugs, and they're just as good as the originals. And the likely savings for the health service in Europe, which at the moment is about 20 billion, will be about 2 billion. So it's a 10% reduction in going into a relationship of trust with these drugs. And just because they're called biosimilar doesn't mean to say that they're not going to work. They do work. And as you say, eCancer has just put up online an excellent educational program for those clinicians out there who actually haven't come across biosimilars yet, but they maybe should be if they're going to cut down their health budget.
If it costs less and does the same, then there's very few reasons to not think it's a good idea.
I can't think of one.
Well, that leads us with only the awards to discuss. The award for Women for Oncology went to AACR President Margaret Foti at ESMO this year. Can you tell us what the award means in the field?
Well, anybody who's dabbled in cancer research will know Marge Foti. She has been the pioneer in communication of research results via not just cancer research, which was the AACR sort of big signal journal, but I think she spawned 15, 16 more journals as the whole area of cancer research got split into little silos, and she is just an absolute giant in the field of cancer research. She's a superlative leader. She's built up AACR. She has had an influence right across the world, and I cannot think of a single man who can outmatch her, never mind woman, in getting the Women's Award. And if I were awarding the most prominent person in the area of cancer research in terms of what we do at eCancer, also disseminating it and getting the word out there, then Marge Foti would get my vote every time, and she's a lovely woman.
Okay. So that's all from us at ESMO this year. We'll be back sometime soon with news from conferences around the world. We look forward to speaking with you then.